All right, let's dive into this clinical guide for diagnosing an acute patellar dislocation. Now, we all know it's a common injury, but here's the thing. Confirming it after the patella has already popped back in, that can be a real challenge. We're going to break down a clear, evidence-based approach to help you nail this diagnosis. So we're going to follow the whole clinical reasoning path. We'll start with why this diagnosis can be so tricky, then we'll get into risk factors, what to listen for in the subjective, what to look for in the objective, and how to put it all together for a final diagnosis. And of course, we'll wrap up with the key takeaways. So let's start with the number one problem you're going to face in the clinic: trying to diagnose a patellar dislocation when the patella is already sitting right back where it's supposed to be. And that right there is the million-dollar question. It is incredibly rare for a patient to walk into your outpatient clinic with their patella still visibly dislocated. So your diagnostic skills have to rely on reading the signs and interpreting what happened after the fact. So how does it go back in so fast? Well, most of the time, it's just a simple reflexive contraction of the quadriceps. The second the patient reacts to the injury, that muscle fires and just pulls the patella right back into its groove. This means you're basically diagnosing an event that's already resolved itself anatomically. But the key is, the underlying tissue damage is still there. Since you probably won't see the dislocation yourself, you have to become a bit of a detective and build a really strong clinical case. And that process starts with understanding the risk factors that made this injury more likely to happen in the first place. What you're looking at here are the big ones, the key risk factors that basically create a perfect storm for instability. Now, some of these things are fixed, like the shape of their trochlear groove, but many are things you can spot in your clinical exam, like genu valgum or a high-riding patella. Seeing those should immediately raise your suspicion. One of those risk factors you really need to be aware of is generalized hypermobility. It's a huge one. It tells you there's likely some systemic laxity in their ligaments, which definitely can affect the stability of that patellofemoral joint. And lucky for us, we have a standardized tool to check for it, the Baton scale. The Baton scale is your go-to here. It's a super quick 9-point screen. You just give 1 point for each test they can view. And remember to score the left and right sides separately. If you get a score higher than 5, that suggests generalized hypermobility, and that's going to seriously inform your management plan. You'll be thinking a lot more about motor control and dynamic stability. So what's actually happening on an anatomical level during a lateral dislocation? Well, the main structure that gets damaged is the primary restraint on the medial side. We're talking about a tear of the medial patellofemoral ligament, the MPFL, and the tissue around it. This is almost always involved, and it's the key injury you're looking for evidence of. All right, so with that anatomy fresh in our minds, let's talk about the subjective assessment. Because honestly, the patient's story is often where this diagnosis really starts to come into focus. This is pretty much the classic story you're going to hear. The patient will describe this really distinct feeling of something shifting out of place and then a second separate sensation as it pops back in. When you hear that specific description, that's highly suggestive of a true patellar dislocation. Okay, let's move on to the objective exam. This is where we're going to find the physical evidence to back up the hypothesis we formed from the patient's story. First up, observation. And this is a really big one. Think about it. Most patellofemoral pain syndromes show up without a big swollen knee. Well, acute patellar dislocation is the exception. When those medial structures tear, they bleed into the joint, causing what we call a hemarthrosis. Seeing that significant swelling is a major objective sign. Next, you're going to want to get your hands on the knee. Palpation gives you direct proof of where the injury is. You should absolutely expect to find some pretty distinct tenderness right along those medial structures, the MPFL and the retinaculum. Also, make sure you palpate the lateral femoral condyle. That's where the patella may have slammed during the dislocation. And check the patella facets too, because tenderness there might point to a chondral injury. Now, when it comes to special tests, if you only remember one test for this condition, make it the patellar apprehension test. It is absolutely your primary diagnostic tool. It directly tests the patient's sense of stability and is highly indicative of a past dislocation. And here's exactly how you do it. You put the knee in about 30 degrees of flexion. This just gets the patella out of the deepest part of the groove. Then you apply a very gentle lateral force. Now, a positive test is not about pain. It's about the patient becoming visibly worried or apprehensive. They might even grab your hand to stop you because that movement reproduces the feeling that their knee is about to pop out again. Just make sure you always warn them what you're about to do. A couple of other quick checks can help fill out the picture. A gentle, resisted quad set might bring on pain around the patella, not in the quad muscle itself, which points to irritation of the injured tissues. You can also watch them extend their knee and look for a positive J sign. That's where the patella clearly tracks way out to the side in the last few degrees of extension, which is a sign of maltracking. So let's pull all of this together to confirm the diagnosis and, just as importantly, make sure we've considered other things that could be causing the patient's symptoms. And that brings us to the diagnosis itself. The key thing here is that it's a clinical diagnosis. You typically don't need imaging right away. You can make a really confident diagnosis just by combining these four things: the classic pop-out, pop-back-in story, the presence of that hemarthrosis, that specific tenderness over the MPFL, and a positive apprehension test. But of course, you always have to think about what else it could be, especially in certain groups. With your pediatric patients, for example, keep those growth plate issues in mind, like Osgood-Schlatter at the tibial tubercle or Sinding-Larsen-Johansson at the bottom of the patella. And for patients of all ages, it's possible you're dealing with an isolated chondral injury or even a symptomatic bipartite patella, which can look pretty similar. All right, let's wrap this up by summarizing the most critical points that you can take straight into your clinical practice. So here it is in a nutshell. If a patient comes in with an acute, traumatic, swollen knee, your first thought should be patellar dislocation. Listen for that classic story of it popping out and back in. When you palpate, zero in on those medial structures. The apprehension test is going to be your most valuable tool for confirming it. And finally, always, always look for those underlying risk factors, like hypermobility, to help prevent it from happening again. And that's it for this explainer, so I'll leave you with this to think about. The next time you have a patient with an acutely swollen knee, what are you going to prioritize in your objective exam to really lock in that diagnosis? Thanks for watching.